Hi, it's Dr. Centeno, and thanks for joining us. I'm running a little late today. We'll have to see. I'm up not at my usual broadcast spot, so hopefully all this works from here. Just trying to get something out today. I missed last week due to Christmas, and hopefully I'll be able to get something out today for everyone to consider. We're going to be talking about tendon dry needling. Came to my attention maybe a week or two ago. I think it was two different patients who had sent me some information on this tendon dry needling, and they were going to go and try to get it because they were convinced it was the thing that was going to help their craniocervical instability. So I wanted to make sure that I went over this and really took a look at it and tried to give you my sense of it. And so that's what we'll be talking about. Let me see here. I'm going to go ahead and first try to share my screen. So we'll start as usual with a presentation, and then let's go with the entire screen. And then we'll go from there and answer questions here. So the title today is Can Dry Needling the Suboccipital Tendons Fix Craniocervical Instability, or CCI? So I've seen videos popping up showing some improvements in C1, C2 overhang after trigger point dry needling. One a patient sent me was probably within the margin of error of the measurement, meaning that all of these measurements have margins for error. So when they're reported in the tenths of millimeters, like 3.2, and that improves to 2.8. It's probably within the margin of error of the accuracy of the read. Now, obviously, if something goes from 5.0 millimeters to 2.5, that's outside of the margin of error. So the margin of error is at least approximately 0.3 millimeters to 0.5 millimeters in any of these reads. So what was interesting to me when I looked this up and kind of tried to get a sense, it was a chiropractor that was doing this trigger point dry needling of the tendons and claiming that he had discovered something magical and new. In fact, we started doing trigger point dry needling in the mid to late 1990s. And the good news is that it was very effective treatment, and we could even help some people who had dizziness. The bad news was the results were usually short-lived, and in the unstable population, they were really short-lived. And then some of our CCI patients just wouldn't tolerate it at all. So what is trigger point dry needling? That's when you use an acupuncture needle to needle or poke holes in the trigger points within the muscles. Trigger points are places in the muscle that are painful and not working due to nerve irritation. You can also needle the muscle tendons. You've got tendon, muscle, so you can do that as well. So why perform dry needling of muscle tendons? Well, the muscle tendon is where the muscle attaches to the bone. And this area can get beat up and inflamed, or it can get what we call tendinopathy or tendinitis. And that can have an effect of shutting the muscle down. So that would, in CCI cases, actually increase the amount of instability, because you need that muscle for stability, or these muscles up here. Now, dry needling the tendon causes bleeding within that tendon, and it's the blood and the platelets in the blood that can help kick off a healing reaction. So it's not a bad idea, but as you'll see, it's probably not a solution for most CCI patients either. So why could this help a patient with CCI? Well, the suboccipital muscles are only half of the stability equation. The other half is ligaments. Now, if you've seen me as a patient, I'm always telling patients, hey, half of what I can fix are the ligaments, but then there's another half of that stability equation, and that's the muscles. So you've got to get the muscles online and working. And this could help get the muscles online and working. If you were to really trigger point dry needle the muscles, you'd probably also want to do some tendon dry needling where it was tender. So that's not a bad thing, right? It's we're trying to get the muscles back online. You're also going to need to do strengthening with that as well. But it's important to understand how all of this works. And this is where I think patients get confused. So let's look at ligament and muscle function in that stability equation. So we have a theoretical joint here, right? Let me see if I can use, I don't have my crazy wide screen today, so I should be able to use the pen. So obviously we have a muscle that I drew here, and then we have a joint capsule that I drew there. And this is our joint right here in the middle. Now, if we move the joint just a little bit, the muscles stabilize in what's called the mid-range. So the middle portion of that is where the muscles stabilize. So that's how the muscles work to keep things going. Then, if we move the joint more towards its end range of motion, meaning where the ligament should stop the joint to protect the joint from damage, the muscles aren't really doing much anymore. It's the ligaments that are doing the job. And you can experiment like this with your finger joint, right? This mid-range is controlled by the muscles in your forearm. But once you get to the end range here, the muscles aren't doing anything. It's the ligament that is preventing that. And in that case, the capsular ligament, or what's called the palmar plate. Hence, if you help muscles and tendons work better, you improve the mid-range, but you really do nothing for the end range. So for example, your ability to function in slow and dedicated movements in the middle of the range of motion would improve. So if you were trying to do a C1, C2 overhang, and to the extent that some of the overhang was due to muscles not working in the mid-range, that might look a little better if you weren't stressing the ligament out. But once you get to that end range and really put pressure on that ligament, the muscles aren't doing anything, and it's the ligament that has to prevent the joint from damaging itself. So that's not going to improve that end range. And again, and I've said this before, and I'll say it again and again and again and again, the ligaments are half of the stability equation. They work at the end range. But that mid-range is also important, and that's those muscles. So through strengthening, trigger point dry needling, treating, getting PRP in the tendons, anything you can do to get the muscles back online is a critical part of getting better with CCI. So let's look at this from another direction. Is dry needling the most powerful way to help tendons heal? Well, we did this experiment already. And the answer is it really isn't. So if you look at these different things I have here, dry needling, prolotherapy, high dose PRP, bone marrow concentrate, dry needling is going to be the least effective, prolotherapy a little bit more effective, high dose PRP more effective, bone marrow concentrate the most effective. And this is from our 2019 paper on this topic here. So if you look at what we did here, these are tendon cells, and this is a scratch test. So we basically created a gap in the tendon cells, and tendon cells like to bridge the gap when they heal. So you can see here, if we use 0x, meaning platelet poor plasma, we don't really get much closure at all of that gap as we go across from 0 hours to 48 hours from left to right. But if we do dry needling, which is just going to be 1x PRP, meaning just the amount of platelets in your blood, then you see you get a little bit of closure of the gap. But if you compare that to something like 14x PRP, which is what I have at the bottom, or even 4x PRP in these younger tendon cells, there's no comparison. The higher dose of the platelets is causing those tendon cells to fill that gap and heal much more quickly. So we routinely inject the suboccipital muscle tendons with high-dose PRP or BMC in all PICL and/or posterior procedures. So it's one of those things where, you have to ask the question, why is this an important thing to get these tendons dry needled when we're already injecting these areas with platelet-rich plasma or bone marrow concentrate as we exit during the PICL procedure, and we're injecting the associated facet joints. So you've already had a stronger treatment than someone can do with tendon dry needling, and those tendons are already treated as part of a posterior procedure or a PICL procedure. So in conclusion, trigger point and tendon dry needling can be a valuable tool in the conservative management of CCI when combined with those select specific physical therapy exercises. So that's the good news. However, the effects tend to be short-lived when it comes to just dry needling. You've got to also combine that with strengthening, but as you know, many of our CCI patients can't strengthen because of that ligament end range problem. So that's not going to be fixed by tendon dry needling. So the bottom line is, in addition, if you're concerned about getting those tendons treated, because many of those tendons do have tendinopathy, they're already treated as part of a posterior injection or PICL procedure. And that's it. Let me get out of that here. We'll stop the sharing. Hopefully this internet connection remains stable, but we will have to see there. Looks like probably did. Okay, so let's go with questions here. Dr. Centeno, hope you had a nice Christmas break with your family. Oh, thank you, Rishi. Yeah, I had a very nice break. It was great. Rishi, to create plate lysate, I thought this had to be freezed overnight. When I had my PICL with you, this was made a couple of hours, used the same day for hydrodissection. Am I mistaken? When I'm making plate lysate, it has to be freezed overnight. Yeah, Rishi, if all you've got is a little medical office, then that's how you have to make platelet lysate. We obviously have got $1 million lab. So if you're going to throw platelet lysate in a freezer, and if you're a Regenix affiliate, you don't have $1 million lab. So you're going to use a negative 20 degrees C, which is your average freezer, right? That's about what your freezer in your kitchen is. And that's an overnight freeze. Now we use a negative 80 to freeze our platelet lysate. We also do other things to maximize the growth factors. So the platelet lysate that you're getting actually has much higher growth factor content than just an overnight freeze platelet lysate. But at negative 80, we can freeze that down in 20 minutes. So it just has to do with much more sophisticated lab equipment that we have at Centeno-Schultz Clinic, because we've got $1 million clean room lab where all this stuff is processed. It's one of the reasons why I won't let anyone else do the PICL procedure at this point, because I'm very concerned about the possibility of infection in this space, and introducing infection outside of a clean room is always a concern for me. Rishi, if the patient knows symptomatic relief from PICL1 and does another DMX to confirm if overhang is reduced, how can this be used to see if there's a reduction in overhang? Reason for asking this, because the patient won't bend the same exact way they did the first DMX, or stand in the same exact position. They may not bend as much. Yeah, so I think, Rishi, what you're bringing up is trying to make sure that the amount of bending is the same between those two DMXs. So there's two components there. One is the amount of bending being the same. The other is the speed at which, or the velocity at which, there's a change in displacement. So we're looking at both of those things. The first is, did the person get to the same amount over? And the second is, was there a big change in the amount of displacement? So meaning, as that person goes over 10 degrees before, it just, boom, slips very quickly, fully over. Versus as they go 10 degrees in this repeat DMX during about the same time frame, is it more slowly moving through that displacement? So those are the two things we look at in trying to compare. Light Hope. I'm currently taking supplements containing turmeric, scheduled for PICL procedure next month. Can you take the supplement or stop? No, you can continue taking turmeric. That's fine. The one you really want to stop before a PICL procedure would be fish oil, because that can cause some thinning of the blood or increased bleeding time. Rishi, if TNCC count doesn't matter for procedure outcomes, why should genetics sell a stem cell support formula? Yeah, TNCC is not a stem cell count. So that's important to understand. So TNCC is total nucleated cell count, of which a portion of those are stem cells. A stem cell support formula, the concept there is to try to improve the health of the stem cells based on the lab experiments we've done with those supplement components. But a TNCC doesn't give you a stem cell count. It's a proxy. It's a rough proxy for a stem cell count, all things being equal. But it's just the total number of nucleated cells in the sample, not the number of stem cells. Bo, I have symptomatic 3A and 2B. What can I expect after my in-person evaluation if I'm considered to be centrally sensitized in regards to being able to receive PICL above the atlas? Yeah, Bo, as I think I've always said, if you're in that fragile egg category and centrally sensitized, we're probably going to stick with just below the atlas, or dramatically reduce the number of procedures simply because of a concern about pushing you over the edge. So there are times we might go above and below the atlas, but only do PICL and nothing else. We won't do any posterior work if the person is very centrally sensitized. We won't inject into the facets. We won't treat nerves, etc. So that's generally how that works. Light Hope, I've had 4 rounds of cervical prolo. My lower neck feels stable. I noticed that my upper neck feels very unstable. Do you know what may have happened? I don't know what kind of CCI you have, so very difficult to discuss, meaning that when it comes to craniocervical instability, there's really only one kind, and that would be a 3A that would be very readily treated with posterior cervical prolotherapy. So that would be C2-3 moving forward in flexion. For type 2B, it's not going to move the needle at all. So that would explain, if you have 2B, for example, why you didn't get any results in the upper neck. Rishi, when should strengthening exercise be done post PICL? You just have to clear it with your doctor, Rishi. So I would just email your doctor and give the report. Normally we don't start stuff like that until the patient is 3-4 months out. They're starting to see some improvement, and then the doctor has to give the individual thumbs up. Light Hope, if we have been scheduled for PICL, the provider than yourself, if we would like to schedule with yourself, is that possible? That's something you'll have to check and see. I don't know what my schedule is, obviously, sitting here. It's possible, but I don't know if it is something that is probable. So that's something you would have to call my scheduler about, Sherry, or reach out to whoever scheduled you and say you'd like to switch, and then they can try to see what's doable there. Light Hope, I noticed that my left side of my neck, my SCM is completely turned off. Will the PICL help with getting the signals back online? Certainly possible. SCM is very much controlled, we know, by C1, C2. And so if there's an issue at C1, C2, that may have turned the SCM off. Obviously, treating C1, C2 and the instability there may help that. Light Hope, post PICL, I plan to just walk and continue AO treatments for 6 months. Do you feel as though PT should be started prior to 6 months? A lot will depend how well you do. So if you've made very good progress from the PICL, that's something that you'd want to reach out to your doctor about and get approval to start exercises. The specific exercises, I would say in most people after a first PICL, if you're not within that first year and a half or so of the injury, meaning you're farther out than that, it's unlikely it's going to make much difference, because usually we wouldn't start the exercise in most patients until after PICL2, but there are some that make enough progress with PICL1 where the doctor may want to start them earlier than that. Bo, if I'm considered to be centrally sensitized, what are your thoughts on ketamine therapy to help in any way in hopes to better achieve PICL above the atlas? Yeah, Bo, problem with ketamine therapy is it will completely destroy your ability to be put to sleep easily during the procedure and make your procedure extremely difficult for the doctor and increase your risk from anesthesia. So I would say ketamine therapy would be a bad idea because it will just end up increasing your risk of not getting much done, because we can't get you to sleep because you're at that point addicted to or have gotten used to ketamine, and that's going to make it much harder for anesthetic agents to work in you. So not a good idea, regrettably. Light rope during the pre-op physical appointment, what should be expected? Hands-on physical exam is usually where we go. Usually repeat the history again, try to see if we can dig a little deeper on history. We'll look at the films again, try to make sure we have it all correct with regard to the types of CCI we're treating, trying to find injection targets on physical exam. For instance, do we inject the right third occipital nerve versus the left lesser occipital nerve? Do we inject and hydrodissect under the sternocleidomastoid or not? Do we inject the bilateral C1, C2 facet joints or the bilateral C0 through C3 facet joints? All of that kind of stuff. Light hope. How do I determine if someone falls in the fragile leg category with PICL, blah, blah, blah. So generally, no. And I'm going to have to start skipping down here because a lot of questions from one viewer. But bottom line is centrally sensitized fragile leg patients are the patients that have a really hard time tolerating any kind of hands-on exam. So for instance, a massage would make them much, much worse. Or the kind of patient who, if they had an injection in their neck, let's say prolotherapy, like you said, it would take a very long time to recover from that prolotherapy. So if you've had prolotherapy, I think you had written that in the past, then it's not something I would be too concerned about. I'm going to skip down a couple of questions here just because I want to make sure I get to everyone's questions. Ian, where exactly would you suggest dry needles should be placed to help CCI? Apologies if you cover this in the video after I sent the message. Yeah, it's trigger point dry needling of the suboccipital area. Now, you've got to make sure you have a very experienced trigger point dry needler because, early on, I realize we've been doing trigger point dry needling since the mid-1990s, but early on, I would say maybe around the 2000 timeframe or so, we had one of our providers who was doing it that put the needle in too far and ended up getting a subdural hematoma. Haven't had anything like that since, and I think that provider who's now moved on has since corrected their technique, but it's not a zero-sum game. So you would have to have a provider who's very comfortable with doing that kind of trigger point dry needling in that area. I would definitely recommend that trigger point dry needling be done under ultrasound guidance so you can avoid things like the third occipital nerve, the greater occipital nerve, the lesser occipital nerve. So it's not going to be your common physical therapist or acupuncturist who wants to stick some muscles in needles. It's going to be a highly specialized provider who's using imaging guidance with the trigger point dry needling. Centeno-Schultz, advanced by Sherry, is dry needling something that would be done before or after a PICL or not at all? Most of our PICL patients won't tolerate it. For the few that would, it could be done certainly before and after a PICL procedure. After could be a little rough. So I would say in most patients who could tolerate it, before would probably be better. Light hope or other Regenexx providers performing C0 through C3. It was told C0 through C3 injections performed, but yet my upper cervical area feels very unstable. What may have happened? Again, if you have a type 2B, that's not going to help, meaning injecting 1-2 from the back isn't going to help. You would need the alar ligament injected. The only way to do that is from the front through a PICL procedure. Again, we don't recommend any clinic outside of Colorado for C0, C1, and C1, C2 procedures, simply because any clinic we could recommend probably doesn't do enough to have the expertise at those levels, meaning you would have to do those levels minimum hundreds of times a year to be very good at it and to avoid some of the pitfalls. You'd have to have digital subtraction angiography, on your C-arm and other stuff. Centeno-Schultz, advanced by Harry Winston, is dry needling something algo cells can do? I don't know. That's something you'll have to check with those guys on. Ian, what are the main indicators of cranial settling versus vertical instability that can be seen on diagnostic scans? Well, cranial settling is usually determined by a low Bayesian Dens index, or BDI. So if you were to measure the distance from the Bayesian to the Dens, you're going to see that decrease. Now, the normal distance is considered 12 and above, but that's may not be the normal. Based on a new upright MRI study, you might be able to take that down to 7, but that study wasn't done with symptomatic and asymptomatic people to compare. So suffice it to say that if you see a Bayesian Dens index, let's say of 4, that's very suggestive of cranial settling. Another thing, if it was very severe, would be the odontoid can even poke into the foramen magnum and violate that line that goes across the foramen magnum, but that's going to be a very severe scenario, and that would be a surgical case all the time. Sharon, hi, Centeno, I hope you're doing well. What determines whether or not the tendons can heal? It's the amount of wear and tear on them versus your ability to heal them. So if the amount of wear and tear is high, sometimes the only way to get them to heal is to do an intervention. Usually these days, that's high-dose platelet-rich plasma. That would be the most effective way to get a tendon to heal. It would be, anywhere from 5 to 10 times more powerful, for example, than dry needling in the ability to get the tendons to heal based on the research we've done. Rishi, do the subaccipit muscles get injected in all PICL patients as a standard, and is this injected with PRP or BMAC? Could be either PRP or BMAC. I don't know for the other providers doing PICL, but for all of my patients, when I'm injecting the upper cervical spine and facet joints, which is very, very common, I'm also injecting the tendons on the way out. Or if there's a specific reason based on exam that shows that a tendon is very much involved, I will inject that separately. And so, for example, a big one that's not uncommon is the lateral transverse process of C1, where the obliques come in, and a lot of patients will come in and say, I've got pain right here. What is that? And so that's an example where specifically we're targeting those tendons with high-dose PRP or bone marrow, depending on what we have. Sharon, sorry I pressed the enter button too soon. I mean either PRP or stem cells. Well, PRP works very well for tendon healing. If we have bone marrow concentrate left over from a PICL procedure, which we frequently do, we'll use bone marrow concentrate. If not, then we'll use high-dose PRP because it works very well. David, hi, Dr. Centeno, I wonder if you have observed increase in CXA and CCI patients after PICL procedures. Haven't observed that, but realize, David, as we're not, so there's a couple of things around CXA. The first is that CXA is highly dependent on the cervical lordosis. So if you've got no lordosis, then your CXA is going to increase. If you increase if you've got an increased lordosis, your CXA is going to increase. If you've got no lordosis, it's going to decrease. So bottom line is, if you have small changes in how the patient is imaged, so is the patient image lying down or seated, you'll see a change in the CXA just based on what's going on in the lower cervical spine. The second thing would be that we don't consider CXAs to be pathologic until they get into the 125 range or so. So if you've got a CXA that is 131 and the next image it's 134, that's probably within the range of error of that measurement. But let's say it really did change, not so concerning. So no. And then the third issue to bring up is we're really concerned about the collapse of the CXA with flexion, more so than about the CXA in neutral, meaning most patients don't have a lot of symptoms in neutral. Most type 1A CCI patients that have a low CXA get that issue when they look down. And that's when the CXA collapses and really puts a lot of pressure on the brainstem. So those three things to consider. Rod, Hey, doctor, appreciate your offer, number one, regenerative treatment, but yours come at a massive cost. Is it okay to try PRP for cervical instability, lower concentrate than yours to give it a go? I don't know what we're treating, Raj, so it's very, very hard to understand the question you're asking, meaning if you have CCI, what kind of CCI? Type 1A, type 1B, type 1C, type 1D, type 2A, type 2B, type 3A, type 3B. The second question would be, what is the goal of the treatment? Are we treating just the ligaments? Are we treating the joints, for example, the facet joints, the nerves, etc.? And then the final question would be, what is your age? Because that makes a big difference in how concentrated the PRP should be. Bo, I've been receiving Procaine using a needle to put all over head, neck, shoulders, spine every month, and it seems to help. Should I stop this prior? Yeah, because Procaine would be toxic to what it is we're putting in there, so I wouldn't recommend doing ongoing Procaine injections. And it's a concern because Procaine can be myotoxic. And we certainly know it's neurotoxic. Now, being neurotoxic in a centrally sensitized patient may not be all that bad, meaning that if it kills off little free nerve endings, that could help the patient. But I would be very concerned about getting PRP in any of the areas we want to inject. I would give it at least a month. David, also, what about decrease in grab oaks after PICL treatments? Again, David, our focus is what happens to these measurements in movement, not the static measurement itself. So same rules would apply that I just talked about. So same ideas. Sharon, I've been doing AO, but keep slipping out of adjustment, but I feel like I get more unstable and muscles are not working anymore the way they did. Likely need regen. Can AO adjustments make you more unstable over time if it's done the right way? I don't know that. I think some things to try, obviously, would be see if you can tolerate the exercises, because, again, you've got to get those muscles stronger. If you can't tolerate that, then perhaps checking to see if there is tendinopathy in that area, because that can shut down muscles, and getting that treated with some ultrasound-guided PRP shots. Obviously, another would be getting additional deeper stability injections, for example, like PICL. Raj, doctor, if you sprained your neck with probable cervical instability or CCI or ligament and soft tissue. Yeah, Raj, same question as before, so that doesn't tell me a lot. Wait for a few months. So I think for any thing like that, I would wait a good 6 to 8 weeks to see if it all calms down on its own. And I really wouldn't consider regenerative treatment personally until I was in the 8 to 12 week mark if I wanted to be really aggressive, or after 12 weeks if I didn't want to be really aggressive. So I think I can answer that part of your question. Zigzag, is a deviated uvula meaningful cranial nerves and CCI, or is that idea a myth? I mean, it could be related to some cranial nerve 9 issues. Depends on how deviated, whether it's deviated because it was structurally built that way and you were just born with it, or is it deviated because the muscles aren't working? It also can be deviated due to scoliosis as well. Rishi, are you able to list off what are the standard structures are commonly injected in all PICL patients? I know each patient has a custom treatment plan. So Rishi, if we're injecting below the atlas, we're injecting usually the lower portion of the alar. In some patients, that will flow into the upper portion as well, but that's probably only 1 in 3 patients or so, maybe 1 in 2 that will see that. We're injecting the transverse ligament, and we're injecting the anterior longitudinal ligament at C2 there on the exit. When it comes to above, the standard structures for PICL would be the upper portion of the alar ligament, apical dens, the AAOM, at times the tectorial membrane, although that one's higher risk, so we probably wouldn't do it unless there was a type 1A CCI. And on the way out, the SAAOL ligament. Raj, will you have more PICL clinical trials in the future? We have one ongoing now, Raj, but you would have to have, not for an acute injury, and we would need to know what kind of CCI. Anson, do you consider patients upon new information, you reassess me a candidate for PICL last year, then recommended as a candidate for PICL, then recommend a surgeon. Surgeon said I don't need fusion, but have the PANIS, possible ligament injury. Sure. Yes, we do that all the time. Sharon, at what point of time do you include PRP or PICL is not working for a patient? If you don't benefit from the first round, does that mean it's not doing anything? Meaning, should I get some relief at least the first time? Take a few rounds before getting any improvement. Yeah, Sharon, we usually want to see something that we can hang our hat on from that first round. So many times, for instance, we'll repeat a DMX to see if there's been an improvement, let's say in C1, C2 overhang or C2-3 translation or something. Now, there are times that we're not seeing much of anything and the patient's so severe and they've got no other options that will allow them, now that we know the safety matrix of the procedure is definitely much, much better than fusion. And if that's the patient's only option, we'll let them do a second one. But if we're not seeing improvements by the second one, I usually won't continue or allow the patient to continue. Rishi, is deep tissue massage only 3 weeks after PICL? It's very functional. I was very functional with PICL and most of the inflammation went down quick. Yeah, that's fine. Levon, hi, Dr. C. If pulsatile tinnitus persists post-PICL, would you say it's a good idea to perform cervical 3D CT with contrast to see where the issue lies prior to next regenerative procedures? I think maybe what you're bringing up is a MR angiogram or CT angiogram or CT venogram. We could do that. It's just an immense amount of radiation, about 100 chest x-rays. So we normally don't like to do those unless there's some specific reason to do them. So if you had some improvement with some things, but the pulsatile tinnitus didn't improve, we'd probably just do another PICL and see if the pulsatile tinnitus improves rather than exposing the patient to that massive amount of radiation, because I don't think we're going to do anything any differently if we see some compression of the internal jugular vein at that juncture. Levon, conversely, is it possible to get pulsatile tinnitus from anything other than atlas axis instability? Would usually be atlas axis, but it's possible to get pulsatile tinnitus from lots of different things, Levon. It's possible to have it from brain tumors. It's possible to have it from problems with blood vessels. It's possible to have it with vertebral artery dissection, for example. So lots of other things. Anson, additionally, rehab medicine doctors recommending a sympathetic nerve block for superior cervical nerve, or maybe the ganglion. Any tips on this procedure in the presence of ligament injection transverse? Yeah, Anson, I wouldn't personally combine those two, so I'm not quite sure which doctor we're talking about here. Maybe if you can give me more information about which doctor is recommending that. Transverse ligament can only be injected from the front through a PICL, so it can't be injected from the back. Now, if you've got severe sympathetic overdrive and anxiety, we have seen some patients that get a cervical sympathetic ganglion block that helps temporarily, but still the way to treat it is still to treat the instability if that's the cause. Now, there are obviously other things that can cause that outside of CCI. XX, once PRP is injected, let's say 3 to 6, does it now saturate the areas providing more healing and stability? A lot of that depends where it's injected 3 to 6, meaning lots of targets there. You can inject the facet joints, you can inject the ligament origins onto the lamina, you can inject the supraspinous ligament, the interspinous ligament, the intertransverse ligament, lots of different things that could be targets there. The nerve, the facet joint, lots of things. Rishi, how long does it take for PRP to work? Depends on the application, Rishi, but for example, ligament tendon healing is usually in the 3-month time frame. XX, is it possible to be treated by you for the PRP or prolotherapy as it's a same day event since I live out of state? are either covered by PPO insurance. Neither are covered by insurance. We do posterior PRP and prolotherapy injections. And I'm not quite sure of the specific question, meaning that we're frequently doing those injections when we're doing PICL, but I'm not sure if that's what's being asked. Raj, I'm 34. My blood work looks good. I live a very healthy lifestyle. Yeah, so that would be a moderate dose PRP. So you'd want to see PRP for most applications in a 34-year-old in the, let's say, 7 to 10 times concentrated range. So how do you get to 7 to 10 times concentrated? Let's say we need 10 cc's of PRP that we're going to inject in all these different spots. So it'd be a lot of blood. So if it's 10 times concentrated, that's 100 cc's of blood drawn. Let's say a 50% efficiency. So that's now 200 cc's of blood drawn. So it's half a blood bag of blood in order to make 10 cc's of the type of PRP that you would need. If someone's just going to draw a couple of blood tubes and call it good, then you're getting ripped off. That's not going to be very helpful. Robert, is the success rate significantly low for those over age 40 with injuries well over 10 years? Yeah, Robert, we've certainly seen patients resolve in both those. Well, a lot of patients over 40, so that's usually not an issue. As far as injuries over 10 years, I think the problem there is the hole is usually wide and deep by that point. But we have all sorts of patients, right? We have patients who got injured 10 years ago and they're managing their problems and they're not real functionally disabled and they do very, very well. But we've got patients who are 10 years in and they've got extensive neurologic damage from this not being treated for a long time. And they spend all day in bed. Obviously much harder to get that kind of person better. So much of that depends on the functional starting spot. Raj, thank you, doctor. We are lucky giving us free group consultation and grateful. One last question. If you're getting your Atlas and or Atlas adjusted a lot, does it indicate instability? Usually, Raj, and that's something I talk to the provider who's adjusting your Atlas to kind of get their sense of whether or not they think you're unstable. Kimmy, recently told I need upper wisdom teeth removed. Could this cause more instability? Or they're likely not related other than letting the oral surgeon know about my CCI? Yeah, I wouldn't be so concerned about the stability, but I would be very concerned about, if you've ever been to the dentist, right? They put your head in some very strange positions. It's not their fault. They're just trying to get to a specific spot. And they're trying to get good visualization of that spot so they can see what they're doing. So I would be very careful from that standpoint because I don't know how much the dentist can control that. And so you may want to say, these are the positions my head can go in. If we need to do anything else, let me know now before the procedure, and maybe I can't do this right now. That kind of thing. Robert, if ligaments are overstretched more than torn, can PRP stems actually help tighten? Yes, Robert, that's what we see in those types of procedures. And that's really, for most of our patients, what they have. They don't really have a torn alar ligament to the extent that it's torn like a rubber band and pulled back into two pieces. They've got a stretched alar ligament. AT, can hypermobility in lower areas of the cervical spine make it hard for CCJ ligaments to heal? Yeah, it's a good point. We can certainly see degenerative hypomobility. And I think that's an important one to try to treat if it's treatable. We also see the same thing with artificial discs, which are basically the same as fusions. And fusions, where fusions in this area then put more pressure on the upper cervical spine and the patient's CCI gets worse. So it is an issue. Rishi, can plate lysate and PRP be made from bone marrow draw and no blood has to be taken from a vein in the arm? They can, yes. So that's the way we do it at Centeno-Schultz. And for PICL in particular, we do it that way because then we've got a full surgical sterile draw on the stuff that we're using to make PRP and platelet lysate. If we then do a separate draw from the arm, that's going to be obviously still sterile, but it's going to be less sterile than a full surgical prep with drapes and hat, glove, mask, all of that stuff. John, if someone has neck muscle atrophy that causes the upper neck joints to get overloaded and inflamed, which is causing the atrophied muscles to get inhibited, should PRP be done before strengthening? Yeah, John, we frequently inject those muscles during a PICL procedure, and that's one of the reasons to do that, whether we're treating the muscle, the tendon, or both. It's all important to try to help give that muscle the best chance of recovery. Rishi, how long does PRP take to work in cervical facet joints? Not that long. If you look at how long it takes, for instance, to work in a knee joint, I've got lots of personal experience with that because I get my knee injected once a year or so. It's usually 3-4 weeks, somewhere in that time frame. But 1 month prior to PICL, is there anything I can take to help with pain other than fish oil and curcumin? I'll stop fish oil 2 weeks before and stop cannabis a month before at least. Yeah, Bo, just realize again, month before the cannabis we're still going to have issues with the anesthesia. I don't know how long, there isn't any research right now. Cannabis should be stopped, but I think there's some very much longer neurologic rewiring that's going on in chronic cannabis users. So expect the anesthesia to still be more difficult. How long? 3 to 6 months minimum. But we don't even know if that's the right answer. So certainly getting off of it a month before is helpful. As far as what you can use things like Lyrica. If you've got nerve pain, that's a good one. And obviously upper cervical chiropractic, etc. But just realize that we do know that cannabis dramatically increases anesthesia requirements. It makes anesthesia more risky, cannabis use. We also know very little about how long it takes for cannabis effects on anesthesia to completely go away. Light hope. Is it true that if you inject PRP around a joint area, that the PRP solution will be absorbed in surrounding areas and produce the same healing effect? I think if you mean is the same healing effect as in a joint, no, that's not true. John, sometimes when something in my mind or mid to lower neck gets inflamed, my extensor muscles literally feels as if they're a bit squishy when palpated, and it causes my neck to feel bendy. The only thing I can think of there, John, is when the cervical facet joints or the nerves get irritated, the muscles shut down, the stabilizing muscles. So that could be what you're experiencing there. Levon, understood. Cervical MRI states everything is perfect, vessels venous-wise. So I wondered if pulsatitis can be caused by the rest of the cervical brachial than atlas axis. Gotcha. And then Sharon, would wearing a halo frame or a non-invasive traction collar help healing in the right position from PICL? It might, but it would also dramatically destroy your muscle tissue very quickly. So 6 of one, half dozen the other. We'd maybe get a little bit more healing on the ligament, but we would destroy the other half of the stability equation while we're at it. So not a good idea. ETA on AI on website. Yeah, so I'm waiting for the API to be written that allow it to call the custom chat GPT model. So I'm hoping within the first couple of weeks of the new year, but that's what I'm waiting on. But everything else is done. Okay, guys, so I think I've gotten through all the questions. I had a lot of good questions here, and we are coming up on the full hour. And I know got a lot of people probably still at home celebrating with their family, the new year, getting ready for the new year, etc. So I'll probably end it here. Again, thank you for your questions. Today's focus was on tendon dry needling and the concept of dry needling suboccipitals in general. And I will be here this coming Friday. I don't see any reason why I wouldn't be here this coming Friday. And I think the Friday after that as well. So hopefully we'll get back on track here and start doing these and start answering questions again. As I've always said, the goal is to try to make sure people's questions are answered, people are informed, people have some idea of which end is up. And we'll also obviously have this index so it can be watched later. So everyone have a wonderful new year and a wonderful 2024 and New Year's Eve and all that stuff. And I'll be back next week, same bat time, same bat channel. Thank you so much.